So I think we'll get started now. So I'm Dr. Howell. Thanks so much for joining me. Really glad to be doing my first live this evening. And I want to talk to you all a little bit about chronic pelvic pain, what it is, and what we could possibly do to treat it within clinic here. So chronic pelvic pain is really pain that is really anywhere within the pelvic region. So that comprises of your hips, your lower back, your pubic bone, the muscles of your pelvic floor are really all involved within, are all considered being part of your pelvis. And in terms of the chronic part of it, usually anything that's going on for more than about 6 months, we'd call chronic pelvic pain. And it can really be coming from sometimes your reproductive organs, but sometimes it's coming from your urinary tract, sometimes it's coming from the GI tract, sometimes it's more of a musculoskeletal issue. So it really is quite involved. And so there's a lot to figure out when patients come in with pelvic pain. And some of the chief complaints that I'll get from my patients when they first come in to see me, they vary because of all the different systems that could be involved in the chronic pelvic pain. So, they could be complaining of pain with sitting. A really common one that I get is painful intercourse or dyspareunia. Sometimes they'll complain of burning or pain with urination. Oftentimes we'll get things like painful bowel movements, lower abdominal pain, cramping and bloating. We can really see such a variety of chief complaints because of where this pelvic, where the pain is distributed and how many different organ systems are in that area. So, the diagnoses are varied, and the type of tests that we will order also vary because of that. Some of the questions that you'll get when you come in to see us in regards to the history is we'll figure out how long the pain has been going on for, where the pain is exactly. We'll ask things about the quality of pain. Does it come and go? Or does the pain, is it consistent or really constant throughout the day? Does it radiate anywhere? Again, how long you've had it. So we can figure out how chronic this is, if it is chronic, because that really does make a difference in our treatment. Those are some of the things that you would, questions that you would get when you came in to see us. And then in addition to that history, we then do a very thorough physical exam where we're doing, a musculoskeletal exam, looking at the range of motion of your hips, of your back, because that gives us a good idea of what the bony aspects of your pelvis are doing. And then in addition to the musculoskeletal exam, we're also doing a pelvic exam. So it's very different from, the average gynecological exam where there's stirrups, or a speculum, nothing quite like that. We're going internally, but we're actually looking at the muscles and the nerves of the pelvic floor, as opposed to looking at the organs, or looking for movement or pain from the organs of the pelvis. So we're really focused on the muscles and nerves when we're doing our internal exam. So patients come into me, they get this very long, extensive history taking where I really try to figure out what has been going on for the past couple of months, in some cases past couple of years, in regards to their pelvic pain, and really trying to figure out maybe what may be the root cause of their pelvic pain so I can give them a better treatment plan. So I'd like to really jump into some of the questions that I got from the web. Hello, just saying hello to a couple other people from the web. A lot of really good questions came through, and I'm going to read some of them now. So the first one that I got is says, I have one-sided chronic pelvic pain that aggravates during and before periods. I haven't got any diagnosis even after diagnostic laparoscopy, MRI, and nerve conduction test. Only pregabalin keeps the pain a little bit under control. I want to quit all medicines and lead a normal life. How can I manage my pain without taking pregabalin? And is not getting a diagnosis common So that's a great question, and that's a question that really, I would say, reflects a large group of patients that I see in clinic. There are some patients who don't get an immediate diagnosis, that's for sure. And unfortunately, sometimes it does take some time for patients to get the actual etiology or the reason for their pain. And I completely understand patients who want to be medication free, don't necessarily want to take some of these nerve meds for long periods of time. So in this case, I would most definitely recommend pelvic physical therapy because it looks like she's getting a lot of that chronic pelvic pain around her periods. So pelvic floor physical therapy, I think, would be a wonderful option for you. An option to not be able to or have to use medication and still get some good range of motion, manual therapy to be able to work on some restrictions of muscles if that's the case. And acupuncture, I think, is also another wonderful option if you want to be medication free. And then also we in our clinic do an injection protocol. So it's a peripheral hydrodissection, peripheral injections with ultrasound guidance. So what we do with these injections are we're actually injecting anti-inflammatory or steroid into the pelvic floor, combined with an anesthetic or lidocaine. And what that's doing is we're decreasing the inflammation of nerves, desensitizing the nerves, and then with this large volume of fluid, the hydrodissection, we're actually breaking through fascial planes and creating space within the pelvic floor, which would increase blood flow and decrease pain in our patients. So that's another excellent option for you that we do right here in clinic that would allow you to not have to be on medication. So let's move on to the second question that I got, which was also a really good one. Someone asked, what can the cause of one-sided ovary pain that's not cyclical be? So this kind of goes back to what I was discussing earlier, the fact that because of the nature of the pelvis and there being so many different organs that are actually found within it, the GI tract is there, the urinary tract is there, there's muscles and there's bones. So pain in this lower abdominal area could be coming from a variety of reasons. So perhaps it's of a GI etiology, maybe it's coming from a gastrointestinal issue, maybe it's gynecological, maybe it's a cyst, maybe it's torsion, maybe it's more of a musculoskeletal issue. So the differential here is wide. So I would definitely recommend getting or coming in to get evaluated so we can really tease out what could possibly be going on. If necessary, we could order some imaging to give us a better idea of why you're having that pain in that area. So the next question that I got, I think, is very very relevant because I'm getting a lot of patients with these complaints as of recent. So the question goes, can PGAD be a result of pregnancy? And for those of you who don't know, PGAD stands for persistent genital arousal disorder. So that's basically unwanted, unprovoked, sometimes engorgement of the genitals, and definitely arousal of the genitals without stimulation. And sometimes it airs on pain as well. So she's asking, can PGAD be a result of pregnancy? She says, I've never experienced this in my life. Now at 8 weeks pregnant, it's constant. I'm so miserable and I don't know what to do. So the answer is yes, potentially yes. PGAD can be associated with pregnancy. It's been more so studied in coming off of SSRI antidepressants. There's a huge correlation with PGAD and the discontinuation of SSRIs, but it's definitely been found in literature in pregnancy. So it is there is a potential of that. I would definitely recommend letting your OBGYN know what you're going through, because I understand how distressful this can be. I've seen this in my patients many times before, and I definitely understand how much this can really take over in terms of just being comfortable and just just going on with your daily activities. So let your OBGYN know for sure, so he or she can come up with a safe treatment plan for you, and hopefully get you a little bit more comfortable throughout your pregnancy. Let's move on to the next one. The next question says, how to overcome pain with sitting, or ischial tuberosity pain. So this is a great question as well. So this is basically known as ischial bursitis. So the bursa is a small fluid-filled sac. And the ischial bursa sits right on the bottom of the sits bone, which is a triangular bone at the bottom of your pelvis. And the bursa sits between the bone and the hamstring tendons that insert there. And so sometimes that bursa, that fluid-filled sac, can become squished with constant pressure on it, and that kind of flattening of the bursa can cause a lot of pain and inflammation. So one of the first things that I would recommend is trying to rest the area and trying to offload that area. So anytime that you're putting pressure on that bursa, it's going to cause more pain and more inflammation. So you want to try to relieve that area from constant pressure. So we can sometimes recommend offloading cushions. Some ice can be helpful. Sitting on ice using acetaminophen or anti-inflammatory medications is also super helpful in trying to treat that. And then, of course, physical therapy and trying to stretch out the hamstrings and increase flexibility and mobility of the hamstrings is helpful as well. The next one was, is there any hope for a twisted pelvis that causes pelvic, hip, and back pain? She says that the twist occurred in pregnancy number 1 and got worse through pregnancies number 2 and 3. So, this twisting, it sounds like a rotation of her pelvis. Perhaps there's a little bit of hypermobility going on there. Sometimes different rheumatological conditions can cause hypermobility of your pelvis. There's always hope. I do recommend an evaluation to come in so that we can see exactly what the range of motion is, how much flexibility and rotation that we're actually seeing, and to see how it correlates to your hip and your back pain. Again, check range of motion, and we can do different provocative tests and maneuvers to see exactly which joints are involved, to see if you would be someone who would benefit from anti-inflammatory medications. Perhaps you could benefit from an injection, intra-articular injection into the hip, or perhaps an epidural to your lower back. It really all depends. And so a really good and thorough musculoskeletal exam, I think, would be the best bet for you. And so come on in. All right, we have some more questions. So this one says, my question is about a tingling in my perineum that only occurs when I walk. It's not constant, but it comes and goes over the course of the day. I'm taking gabapentin, which is Neurontin, for a burning, itching sensation in the perineum, which is the area in between the rectum and the genitals. So it's a burning and itching sensation in my perineum, testicles, and penis, and it helps somewhat, but it has no effect on the tingling. Is this a pelvic floor issue, or is it something else? So in this case, it could definitely be a pelvic floor issue. That tingling, that burning in the perineum and in the testicles and in the penis could definitely be a pelvic floor issue, but could also be an issue that's coming from the nerves of the pelvic floor. We see that quite often. Sometimes it's pudendal nerve, sometimes it's another nerve that's, or other nerves that are in the lower part of the abdomen. So it could most definitely be neurological. So we recommend coming in, getting evaluated. We would do a pelvic floor exam and see if you had any tenderness along the pathways of very specific nerves of the pelvic floor. And then we would check strength of your pelvic floor muscles to see if and how they were involved, to really be able to decipher whether it's coming from more of a muscular etiology or if it's coming more from a nerve etiology. Sometimes it's a combination of the two. So that would definitely require an internal exam. So another question was asking for strategies for better bowel emptying and better bowel movements. So I thought this was a really important question to discuss, because the mere act of straining or being constipated can definitely wreak havoc on the pelvic floor. Pushing down and putting all that constant pressure on those muscles can be very damaging. So we want to keep our patients as regular as possible. So some strategies definitely are making sure that you are consuming adequate amounts of water throughout the day, that you're moving and staying active. Movement actually would encourage good, effective, healthy bowel movements. So that's important as well. You also want to make sure that your positioning is appropriate. They have different stands and stools that you can actually prop your feet up on. So, it can actually encourage for the directionality of your colon to be congruent to having a good and proper bowel movement. So that's another option as well. Deep breathing is helpful, making sure that you're having a diet that is full of fiber, so that you can bulk your stools and have a good effective stool, is also really, really important. So those are some good strategies for having a good effective bowel movement. Some patients aren't able to have that good effective bowel movement because of the fact that the muscles of the pelvic floor are sometimes asynchronous, meaning that they're not moving in a way that is actually that helps for the body to be able to kind of evacuate the stool. So they're moving in a way that's kind of out of order. So in those cases, patients benefit from something called biofeedback, sometimes in physical therapy. So what they can do is help for you to be able to isolate the muscles of the pelvic floor in a way that you hadn't been able to do before, because there's actually a screen that you're looking at, and there's probes on in the pelvic floor and the muscles of the pelvic floor, and that way you could actually be able to feel and sense what maneuver and what contraction is needed to move a particular muscle of the pelvic floor. So some patients would benefit from biofeedback if they're not able to have that effective bowel movement as well. Someone asked if there's a way to tell if they're having bowel leakage, or is it a problem with incomplete emptying? So, this question, I thought it was a really good question, because it would be very difficult to decipher, for a patient to decipher which it was, whether it was just the fact that they couldn't empty completely, or is it actual bowel contents that are leaking from the rectum. So the leakage usually could be coming from either a nerve issue, could be coming from a muscular issue. So if it's coming from a muscular issue, it would normally be because the external sphincter, which is basically just muscular rings at the end of the rectum, sometimes they're not contracting effectively or properly. So, stool can sometimes leak from the rectum without that contraction. Or perhaps it's a nerve issue. So the nerves that are actually at the end of the rectum by that sphincter that sense the stool are somehow damaged. So that could be involved in bowel leakage. Sometimes it's just mere constipation, or if you're constipated and you have these hard stools that are formed in the rectum, and you're constantly straining to get that out, that can cause weakness of the pelvic floor and then eventually cause leakage. Sometimes just diarrhea in and of itself because of the nature of the stool. It's liquid stool. When the stool is liquid, it's easier to leak out. So there's so many reasons as to why you could have bowel leakage. Incomplete emptying, in my experience, is usually because of the non-contraction or the non-relaxation, inability of the pelvic floor muscles to relax, is usually what I have found the cause of the incomplete emptying. So very different scenarios would definitely require an evaluation, a pelvic floor evaluation, to really tease out which one it is. Sorry about that. Okay, so I think we have another question. Do ab workouts and burpees exacerbate pelvic issues? I get this question often. And the real answer is it all depends. It depends on what ab exercises you're doing. It depends on what, how the form of your ab exercises and your burpees, and depends on what kind of pelvic floor issues you have, or pelvic issues that you have. Patients who have things like diastasis recti, which is a separation of the abdominal musculature. So basically, there's connective tissue in between the muscles of your abdomen, and sometimes after pregnancy or with pregnancy, weightlifting, the connective tissue in between can really stretch out, and there creates a space in between the abdominal muscles. That's diastasis recti. And so when you have these kinds of issues, weak cores, if you do these exercises incorrectly and place a whole lot of pressure around and along your core, it can be damaging, and it can actually make things worse. So that's why I actually do recommend meeting with a physiatrist, meeting with a pelvic floor physical therapist, so they can be able to instruct you as to how to effectively and safely do these exercises, and so that you can actually get the strengthening that you need without actually making things worse. So it really all depends, and I think requires a professional to be able to guide you in that. So it looks like I got some questions while I was talking, so I'm just going to scroll back and see if I can get to some of these. Okay, so someone says, I am 9 weeks postpartum and I had a 3rd-degree tear. My perineum always feels sore and painful. I'm resting nonstop, and the soreness gets worse every 5 days. What could it be? So I guess my question to you is, if did you have an episiotomy? Were there forceps used? Was there vacuum suction used? Because all of that, the details of the labor really, would give me good clues as to what could possibly be happening. When my postpartum patients come in, it's a very, very thorough, detailed history in regards to the labor, not only just the pregnancy, but the labor, and exactly what happened throughout the labor. It can really make a difference as to my differential. But just to very generally answer your question, it could be coming either from perhaps there's muscular soreness, muscular inflammation, sometimes neurogenic or nerve inflammation of the pelvic floor in that region. But if you're able to give me some details, I think I'll be able to answer you a little bit more. I think there's another question here. No, actually, I think that was the last question. Does anyone have any basic questions for me, or any questions at all for me, or what it is that we do here at Pelvic Rehabilitation Medicine? Okay, so we got an answer. So episiotomy and forceps. So the episiotomy in and of itself could definitely, depending on the how and where it took place, exactly what muscles were cut, and what nerves were in that pathway. It could definitely be coming from nerve pain, sometimes coming directly just from muscle pain. And so I would definitely let your OBGYN know that you're still having this soreness. And if needed, you could come in and get evaluated by us. We would definitely do an internal exam and try to decipher pinpoint exactly what muscle the pain is in, and then make recommendations based off of that. I totally understand. She's saying that, because of COVID, she hasn't been able to be seen by anyone. Don't forget that patients are seeing us and also are able to be evaluated by their GYN via telehealth. I know it's not exactly the same because we're not able to get that in-person evaluation, but sometimes even just with a very thorough history, we're able to really be able to give you good recommendations for your treatment plan. So don't discount telehealth if you're not able to leave the house. I would definitely still try to set that up. Thanks for joining, everyone. For those of you who are just joining, my name is Dr. Melanie Howell. I'm a board-certified physiatrist and pelvic pain specialist at Pelvic Rehabilitation Medicine in Englewood, New Jersey. Just went through a few questions that came through on the web. If anyone has any other questions, I'm happy to answer them. Yes, so I definitely do see a whole lot of patients with endometriosis. I would honestly say probably 25% of the patients that I see have endometriosis, perhaps even more. And so with those patients, we do the thorough internal exam, musculoskeletal exam, definitely a focus on the abdomen as well, because there's usually so much pain and nerve pain involvement in the lower abdomen, we find. My patients with endometriosis, we find that they do really well with our injection protocol, sometimes before their lab or sometimes even afterwards, just to help with post-op soreness. So just to talk a little bit more about those injections, I know I mentioned them briefly before, but so they are peripheral hydrodissection, pelvic floor injections with ultrasound guidance, where I'm injecting a combination of anti-inflammatory, so a dexamethasone or a steroid, with a anesthetic or lidocaine into the pelvic floor. And I'm doing that with ultrasound guidance again. What I'm trying to do is I'm trying to decrease inflammation in that area. I'm trying to desensitize those nerves, calm them down, basically. Trying to create space with this large volume of fluid to break through this connective tissue and fascial planes to create space into the pelvic floor, open it up, increase blood flow, increase oxygen to the area, which helps to manage pain for our patients. So someone wants to know more about Pelvic Rehabilitation Medicine Center, the team, the in-house process, special management. So pelvic rehabilitation, we are in Englewood, New Jersey right now. Our clinical headquarters is in Manhattan. We have another location in Great Neck, one in Michigan, one in Maryland, one in Dallas, one in Houston, one in Florida thus far. Each of those locations has a physiatrist in-house, a pelvic pain specialist like myself in-house, and we also have an endometriosis specialist who's part of our group, who does minimally invasive laparoscopies. So it's Dr. Lou, and minimally invasive surgery, pardon me. So we have all of those locations throughout the states thus far. In terms of what we do, we offer many different options to our patients with pelvic pain. We see men and women. We offer different modalities such as medication management. We refer to cognitive behavioral therapy to try to work on the central nervous system. We offer these injections that we spoke of to decrease inflammation, increase space in the pelvic floor. Refer to pelvic physical therapy quite often. We refer to acupuncture. So we really, in this practice, believe in a more holistic approach in treating our patients. It's really a nice combination of, I would say, Eastern and Western medicine, really, in a lot of ways. So someone said, I live in the UK and I'm waiting for a repair on my prolapse and a possible hysterectomy. Due to COVID, the procedure has been delayed and I get a lot of pelvic pain. Okay, so it looks like you have uterine prolapse, and you're thinking about getting, I think you were scheduled to have a hysterectomy. Prolapse can definitely be very painful depending on the level or the grade of your prolapse. If it's a less severe prolapse, like more like a 1 or 2, I find that pelvic floor physical therapy can be extremely helpful in managing not only just the integrity of the pelvic floor, but also your pain. It sounds like it's surgical in this case, so I'm guessing it's more severe in terms of the grade. It depends. If you're having some nerve pain, if you're having muscular pain, there's different medications that we may consider to try to give you some relief until your surgery due to the circumstances. Sometimes there are different topical medications that we may use to help to relieve the pain as well. Anyone have any other questions? Hi, Christina. Thank you, Ty. All right, well, if no one has any other questions, thank you so much for joining me. It's been a pleasure. I hope that I've been able to shed some light on what chronic pelvic pain is and what we do here at Pelvic Rehabilitation Medicine. If you'd like to see us or see me, go to the bio at Pelvic Rehabilitation Medicine on Instagram, and then just click book an appointment, scroll down to Englewood, New Jersey, and you can find me there. Okay, so if no one else has any other further questions, thank you so much. Have a wonderful evening. Stay safe and be well.